Welcome everyone, and thank you for joining today's webinar. I'm Patty Kyler, the founder of Collaborate Health. We're a firm collaborating exclusively with companies affecting real change in healthcare. Today, I'm lucky enough to be your host for the presentation, Caregiver Impact on Social Drivers of Health. A few really quick housekeeping notes before we get started. We will be taking questions throughout the presentation, so just pop those in the questions area on the control panel, and we'll get to as many as we can. If we don't get to your question today, then we will certainly follow up. Additionally, our session is being recorded, so you'll receive a recording and a copy of the slides after the presentation. So now, without further ado, I'm so grateful to be able to introduce you to our speakers. Joining me here today, we have Shara Cohn, the CEO of Carallel, and a longtime advocate for patient and family engagement. Carallel works with health plans to provide support solutions to family caregivers, empowering them to be more confident, capable, and resilient as they care for their loved ones. Welcome, Shara.
Thanks. Great to be here. Thank you.
Also, we have Vanessa Guzman, the president of SmartRise Health. Most of Vanessa's career has focused on building and implementing provider and payer strategies to support value-based care, specifically patient engagement, quality measurement, and data and analytics platforms. SmartRise Health works with provider groups, health plans, pharma companies, tech platforms, and CBOs to align their core competencies to support value-based care, all while prioritizing both community empowerment and understanding individual needs. Vanessa, thanks so much for joining us.
Thanks so much for having me. It's a pleasure.
You're welcome. So to ground today's discussion, perhaps both of you could give us some personal background on why both health equity and caregiving are important to you. Vanessa, do you want to start?
Yeah, sure thing. Again, super grateful to be here with you all today. I think it's been a combination, Patty, of a personal journey as well as my professional career. I am one of the primary caregivers for both of my parents, who are Spanish speaking, from the Dominican Republic, and who have a number of chronic conditions. And I leverage, fortunately, my career, my network of providers and hospitals and payers that I work with to help provide the care that they need, but also I see gaps. I see gaps in the process. As a native New Yorker, being raised primarily within areas of underserved populations, I grew up being a primary beneficiary of Medicaid and really needing assistance growing up. And I see still some of those gaps in access to care to those as I grow up now in an adulting life. And I want to be part of that change. If I was created and designed somehow to live through that path, and now also an expert in value-based care, I'm really inclined to really using my purpose to advancing health equity, specifically in the role of a caregiver now, as both of my parents grow older.
Well, that's wonderful. And change is definitely happening thanks to you. Thanks, Vanessa, for sharing that. And Shara?
Sure. Yeah. Like Vanessa, this is both a personal and professional mission. I've been involved over the last couple of decades in advancing the notion that people can be the center of a care experience, and that they are given the right tools and resources that they can really participate and further our goals as a healthcare system to improve cost and quality. And on a personal level, I identify as part of the LGBTQ community, and what we experience is sometimes different. And so what I see in my peers is often my friends and family circle, that they're often caregiving for loved ones with whom they are not biologically connected. And it changes the dynamic of what's available to them or the barriers that they face. And certainly there are different there are oftentimes different complexities in terms of family cohesion issues and challenges that can create in trying to care for another person. And so, so like Vanessa, experienced this both on a professional and personal level, and really grateful to get to not only participate in these types of conversations, but also be part of the solution for how we address it. So excited for the discussion today and any discussions that come from it.
Fantastic. Thank you, Shara. Thank you both for sharing your personal stories as we jump in. I know you plan to weave that throughout a little bit too, which is so important. I think that health equity and caregiving are both topics that can sometimes get lost in policy and data. And so to remember that it really is a personal thing that impacts most of our lives every single day is so important. So before we jump into your presentations, I just want to remind us what we'll be centering on today. We'll be talking about how to apply a health equity centered approach to caregiver engagement. We'll talk about actionable practices and strategies for patient, family, and caregiver engagement. And we'll talk about the design of clinical and social-based programs to advance both quality and health equity. So just one more reminder that we'd love to get your questions in the control panel throughout the conversation. And with that, I will hand it over to Shara and Vanessa to get started.
Great.
Thank you so much, Patty. I'll go ahead and get started and providing just a lens of how we intend to center health equity throughout the discussion, but also this is also a personal perspective on how we're able to impact health equity. So think of health equity as a centering strategy that over time will become part of, hopefully, our day-to-day operations, right? I think in this climate day and age, we're looking to catch up in filling many gaps that exist across different cohorts, populations, you name it, processes and systems. But I do want to emphasize that I highly feel that it's everyone's role, right, to contribute and advance health equity initiatives. And one of the challenges and struggles that I see among payers and health systems and just healthcare in general among community providers is that what if I am involved in advancing policies and programs, what does that look like? If I'm responsible for building up the infrastructure and governance or establishing governance for my organization, what does that look like? And primarily for today's discussion, if you have a direct influence or indirect influence in patient, caregiver, or community engagement, what does that translate to you? And one of the key items I think that we wanted to discuss today is how we can potentially leverage value-based care and healthcare reforms to really ignite a lot of the action, using it as a funding source, but also as frameworks as we drive change management throughout each of our core competencies, or call it divisions, that we are each responsible for, with the goal of empowering communities in a framework that leverages and understands the community's voice, that also leverages core competencies that are really supported by your individual organizations, and together we can prioritize what those roles and responsibilities are. But this slide is really to center us on the thought that it belongs to all of us and we all have an influence or role in it. And in the same vein, there are a number of different guidance and policies and programs that, thankfully, especially in 2021, is really helping form and shape what health equity and what that looks like programmatically, and also from a budget perspective for several of us, beginning from left to right, with much of the changes occurring at the government level with changes in CMMI's leadership, also CMS putting forth guidelines on addressing social determinants of health. There's also some on the telehealth programs focused on additional dollars for more of the vulnerable populations and supporting providers, not to mention many of the changes that NCQA has proposed and now in effect for 2022, including their multicultural healthcare program, which now is health equity, and they're releasing a pilot program as we speak. So there's a lot of opportunity for payers in particular to really align themselves with providers in the space. And then third, but certainly not least, on the technology piece, ONC's focus on SDOH and how data, policy, infrastructure, and care delivery really is being, at least at a data collection level, being transformed so that we are building equitable streams of efforts, and hopefully will help us better prioritize much of our work and strategies as we move forward. But they're very well-known health equity challenges, I think, that we all seek to address. There's many of you listening today, I'm sure, are responsible for setting up the process or establishing systems to really address health equity and in a value-based care environment especially. So with that in mind, well, the top priority for many of us is understanding how to use existing data, but also very important, collecting data in a meaningful way that helps us identify patients with said disparities. And without the data, of course, there's little identification in terms of where we should prioritize our effort, but it goes without said that there's also areas of opportunity to engage providers, systems, care processes, and also improve the way that we engage with both patients and their caregivers to address some of the hesitancy that occurs, the mistrust and the poor adherence in specific areas, including treatment adherence, and the way that they seek care, that I think we all play an immense role in addressing.
Yeah, so thanks, Vanessa. Maybe what I would like to do right now is just provide a bit of a lens on the importance of thinking about caregivers for healthcare generally, because I find that this is a new topic for many. And yet, ironically, caregiving is so ubiquitous. There are so many of us that are serving as family caregivers. And I think it's important throughout the rest of this time together that I just state clearly, when we're talking about family caregivers here, we're talking about the unpaid relationship to a loved one. So I'm saying family broadly, but I'm also not referring to paid caregivers and that role. So it's important, I think, just to sort of give a lens on the role that those family caregivers play, and then we'll start to dive into what that looks like with a health equity lens on it. But again, there are a lot of folks out there that are serving in that stead, that are serving like Vanessa described in her own family, to help, and those family caregivers, we are heavily reliant on them. And we're reliant on them in many ways, but I think, sort of as healthcare organizations, we're always thinking about what exactly does that mean in terms of cost or performance impact. And so as an example, there's the CBO put out the estimate that about 80% of long-term care is actually delivered by family caregivers, putting a pretty big dent in at-home care costs. So when we talk about costs, there's sort of this unaccounted for army of people that are working on behalf of patients and members, and really they hold the key to better outcomes. So as an example, the chance of a 90-day readmission was reduced in this study by Pitt by 25%. And by 24% when you push that out to the 180-day mark. So the involving caregivers in healthcare processes is absolutely going to drive better outcomes, and particularly as we push more care into the home and into the family. And I think what's important, and what we'll talk more about throughout this time, is that all of that reliance does not come without a cost, that family caregivers are increasingly vulnerable as the complexity and the weight of their caregiving responsibilities have increased. And so we know that 1 in 4 caregivers feel like their caregiving responsibilities have made their own health worse. That 1 in 5 family caregivers suffer from depression, and we see Blue Cross Blue Shield Association put out data recently about the impact it had on chronic conditions and mental health for caregivers. So that load and that reliance again is not without a cost. So when we think about social drivers of health, the non-medical factors that influence health outcomes, we know that the conditions in which people are born and grow up and live and work and age have an impact on their ability to navigate the healthcare system and to do so successfully, and to impact their own health outcomes. And I like the framework that Kaiser uses to illustrate this, and that reliance on caregivers that I spoke of, I think shows clearly, how profoundly they impact community and social context. So as we look across those 6 pillars, that community and social context pillar, the support system that caregivers provide, their presence, their absence, their capability are all a critical piece of the puzzle. But I think it's important to underscore and maybe put some neon lights on the fact that this goes beyond just one point there, and looking at it from a health equity lens illustrates the barriers and vulnerability that exist in the caregiver support system. So there's a lot of data out there around the fact that caregivers, informal caregivers, are more likely to take leave from a job, to take out loans, to spend savings, so financial security, that they're likely to hold multiple jobs, they're likely to leave the workplace, they're likely to retire early, and they suffer harm to intimate relationships. There's increased family conflict, there's decreased mobility and ability to pursue life goals, and these effects tend to be more severe among those with lower educational attainment and can really contribute to a cycle of household poverty. And so I think it's incumbent on us to be aware and sensitive to the differences of the impact that those factors can have on different communities, on different underserved communities, and how that plays out. So on the left, non-white Hispanic caregivers have the highest reported prevalence of caregiving among any other race or ethnic group. The percentage, and these are just examples, right? The percentage of high burden caregiving, meaning that the caregiver is supporting with more than 3 ADLs, is highest among African American caregivers at 41%, and they're spending the most time, on average 30 hours a week caregiving. We, in the LGBTQ plus community, you're twice as likely to be a caregiver as those in the straight community. And lastly, we see the greatest decline in self-reported, self-rated caregiver help in our Asian American communities. So that vulnerability that caregiving can create impacts different groups differently. And so with that, and then thinking back to this construct of from Kaiser, the caregiver capability, the caregiver resilience, is an underpinning of I believe, of a social driver strategy. So when caregivers are vulnerable, it creates strain across social drivers that impact the people that they're caring for. And so, I'll pass it back to Vanessa with just 2 thoughts here, which is, I think that it means 2 things: that caregivers are allies and key constituents in a social driver strategy. The healthcare organization is really committed to addressing social drivers as a way of improving a community's health. Then they need to include caregivers because they're doing much of the work on behalf of the patient or the member. And second, I think it means we need to shore up this resource, that when we talk about community-based care, we have to acknowledge how important caregivers are, and how important they are to the equation. And if we want them to be capable partners, we need to do more than just depend on them. We need to support them and support them as they do that caregiving job within their own life context and within the needs that that they face based on these obstacles that they may or may not face.
Yeah, absolutely, Shara. And you know, to that point, if you go back to your slide for a moment, many of the boxes that you're now boxing in purple, right? Provider linguistic and cultural competency, literacy, right? And then the more apparent, right, or obvious needs that are often captured by just having a dialogue with the patient. You know, I think a lot of it is driven off of what that person or that individual, whether it's the member or the caregiver, has been exposed to in terms of resources. So as we think about also understanding what resources, to your point, Shara, like we need to help them, is also having open dialogues on those, how does the member feel in relation to the caregiver, and understanding what the priorities are for both as individuals before we combine them as a package, right? And I think that leads now to the slide that I have prepared, where it speaks a little bit on population health for a minute, right? And many of you on the line have asked me in the past, where can I start? If you're a payer listening, how can I share resources with providers? And if you're in a health system or provider, you've asked, well, what exactly is the framework? What are payers requiring? So it seems like we're in a bit of a standstill waiting for the other to be helpful. My suggestion here is that we all start from the same opportunities. There are two key showstoppers that I see in healthcare right now is lack of change management experience, or ability to execute in some of the thoughts and ideas and desires that we all have. And the second is leveraging existing resources to be able to execute. So on the change management side, there's a few things. I think we all have a responsibility for setting accountability structures and governance that's prioritized at the very top, but then at a data level, data elements such as race, ethnicity, gender identity, poverty, and education are well-known, sensitive disparity metrics that could be used as slicers to existing quality measures, right? So when we're thinking HEDIS measures, or you're close to renewing your value-based contract, right? And you're deciding on which quality measures and what type of data and what type of shared resources both providers and payers are working through. This is the opportunity to have that discussion in terms of where it's needed and how will it be used to then customize the care for your population. And in this population, many, especially on the payer end, many of us have thought through patient engagement and member initiatives, but without considering, as Sarah pointed out, the caregiver piece. So I think as we all consider shared resources, think about, well, what role can the caregiver play, and how can we collect more information, or how can we interact more with the caregiver so that it becomes a true caregiver plus member engagement programs? Because then by doing that, you'll understand where the support system really is needed, and on behalf of who, the member or the caregiver. And then the second piece, under mobilizing resources, I think risk stratifying the population, and many of you already started screening patients or expanding your screening on SDOH and social determinants of health to include a more probing questions, right? And again, that becomes a really key opportunity to ask, who is your caregiver? Do you have a caregiver? And identify what roles does a caregiver provide. In my life today, I'm more of the back-end caregiver. I'm their health proxy. All things healthcare I do, and any legal or technology-based issue I usually handle, whereas my sister handles more of the face-to-face interactions. So I think also having that understanding is going to be key in how effective you are in carrying some of these interventions.
Actually,
and on the next slide,
Vanessa, just to jump on that point, because this is a challenge that we see a lot with health plans, is that notion of how you identify who has a caregiver, who those caregivers are, and if that is limited to the POA, then you're limited in your understanding, right? Because we talk a lot about caregiving as a team sport. It is often carried by a group of people. There's usually a primary, but there's a group of people that are involved in different ways, and so that data collection piece and the ability to start to understand who is connected to a member or to a patient is just critical.
Yeah, and what their role is. I think that that is key, and that requires further questioning. And I think there's always the question, well, where will we find the time or the resources to do that? But I think without going into that level of detail, and for many of you, right, many of you carry out the what matters most type of interviewing and motivational interviewing approach, that is the opportunity to engage in this level of discussion. So I completely agree. And then to show a little bit about some of the disparities, right, even as we slice the data by some of the SOGI and real data that you're all looking at, just looking, let's say, at flu vaccines, right? And we apply this to COVID, we see a similar trend. By taking just the flu vaccine as a quality measure and applying race, there could be an underlying factor here that you can quickly identify, right? There's certainly less of an adherence rate for the Black and the Hispanic population, and it varies also by region, right, and state. So this is something to consider, especially for payers who are at the national level. It'll be interesting to see the data at a more bird's eye view in terms of what local resources perhaps are necessary so that you can better engage the communities at that level, and how can you enable providers at that level. And those of you that are in the regional space, it's about understanding what type of national resources can be leveraged, right, to bring it down to the community, and then what levers do you have or resources do you have, whether it's in the community, through pharma, through other providers and payer relationships, right, that will carry through some of the education and resources that are required to really address some of these barriers. But this is the type of reporting that I would expect payers and providers to exchange amongst each other as you continue working on quality initiatives.
And I'll just carry that a little bit further on the caregiver side to continue off Vanessa's point. Is I think that from a preventative care, from a population health perspective, thinking about caregivers as both your member or patient and as your partner in caring together for a member. So there are really two personas. As a patient themselves, caregivers report significantly worse health, and unfortunately, this is declining according to AARP data. And caregivers say that their responsibilities have worsened their health, and it gets in the way of them practicing good self-care or managing their own health, doing the kinds of things like getting that flu shot that Vanessa illustrated. And so you'll see this in the ratings of good health as well on the right side. At the bottom of the graph on the right, you're looking at those who rate their health status as excellent or very good, and the national average at over 60%, with a caregiver average 20% lower. But when you also start to look at that with a health equity, an ethnic or racial breakdown, you can see that our Hispanic and African American caregivers are well below the national average and the caregiver average. So I think the punchline here is that it indicates need for specialized support for those that are caregiving, and as I think, not to put words in her mouth, but as Vanessa suggested, specialized outreach, prioritized efforts to encourage caregiver preventative care, because that is certainly the difference maker in our average overall. And then when we think about the second persona, when we look at the role of caregivers and encouraging the health of their loved ones. We all likely know that caregivers assist patients in administering medications and managing daily tasks, and from a population health management perspective, helping make health utilization decisions, scheduling appointments, transportation, those kinds of things. And so this means that the preventative care that we've been talking about is on their shoulders, and there are barriers to that. A couple big ones are health literacy, the resistance versus trying to support the autonomy of a loved one, access issues. We know that 80% of caregivers are helping with transportation. They're the ones who are getting them to appointments, that may be the navigator that can get to more convenient, alternative, newly emerging options for primary care. And I think one of the things that we're finding very interesting and digging into data around is the health literacy piece, and how much the caregiver is responsible for making the importance of preventative care known. And so, I think not to harp on, Vanessa, your personal experience, but that role of a caregiver in doing basic translation, like language translation or even health information translation, is really important. Without getting too far into it, this study that we have highlighted on the right looked at the health literacy associations between elderly Hispanic patients and their caregivers, and found that the pairings of caregiver to loved one, the most common pairing was that the caregivers had the role of the person with higher health literacy, that the adequate health literacy capability rested with the caregiver. And by contrast, only 7% was that flipped, where the person being cared for had the higher health literacy. So again, just to underscore the role as a navigator, translator, driver, health services access determinant, that how important and the primary role that caregiver plays.
Yeah, I think this data screams at us, but we promised to remember that we wouldn't get lost in data.
Yes.
But just making sure that, how do you make sure that the reverse doesn't happen, that you don't pigeonhole someone into a specific category, based on demographics or assumptions? How do you personalize it?
Yeah, I think, and I'll jump in, and maybe Vanessa, you have another perspective here, but I think it's really two things. One is that, and hopefully the tenor of this discussion is, one is just about being aware and sensitive to it, right? To be looking for the differences in our populations, and be listening to that. And the second is then to be flexible and have options for how you fill gaps or how you address it. So you're absolutely right, Patty, that we don't want to swing the pendulum in the other direction and assume that all LGBTQ caregivers are the same, or that all Hispanic caregivers are the same, and that you don't have this cross section of different financial opportunity or experiences, but it doesn't get us out of the responsibility to be listening for those things, for that life context with our members and our caregivers, and having appropriate options given that. So at Carallel, we talk about our HEART model, where we start with hearing and listening to what caregivers are grappling with, and then helping them problem solve accordingly. We may have discussions about the safety of somebody living at home, and in some communities and cultures, it's not an option to think about finding outside help or moving to an assisted living facility. And so what we put an emphasis on, and I think I think everyone should, is listening first and then problem solving accordingly. And so it's about setting up those options.
That makes a lot of sense.
I couldn't agree more. I couldn't agree more, Shara, because I think, and a lot of what you said, it may sound overwhelming to health system trying to process or payer trying to process. How do I package what Shara just said and scale it, right? And I think part of it is it's having it be part of everyone's responsibility to be helpful in a way that one, the listening piece, two, being resourceful in a way that provides options and flexibility to different members or patients or family, but really with the question in mind, who is your support system member or patient, right? Because that translates a little bit different for each pocket or each individual, really, and their interactions with society and resources, especially healthcare, may vary. So I think it's all of the above. I think to systematize it, it would require organizational culture change so that organizations are really building that into their workforce, right? That system of change into the workforce where we empathize and listen with a clear ear to better understand what the support system is for our members and patients.
I love that. I love that. But don't let that fear be keep you in the standstill that you talked about earlier, Vanessa. Okay, quick reminder before you get back to your slides to keep the questions coming in the control panel.
Yes, absolutely. In the same vein and following Shara's discussion, health literacy was touched upon, reading levels was touched upon as key barriers, right, to not only understanding and absorbing and acting on health information, but telehealth sometimes makes it helpful and not, right? So I think there's opportunity there to evaluate our interventions, workflows, partnerships of who we conduct businesses and how we deliver telehealth. But I think this also, when we use the term telehealth, I also want to, it's more of a digital health, right? Or any digital virtual care access. I think the key points here is that we need to work together in partnership with technology companies or other to really design a model that places the caregiver and the patient at the very center, offering options for patients and individuals to really connect digitally. And for it to be as seamless as possible, I work with several partners in the technology side who are basically do everything from device distribution to set up, and that way the individual focuses more on the interaction with the care provider. But of course, because the caregiver plays even a larger role, especially when digital technology, I know I do as a caregiver, that's probably 40% of my job is making sure that the digital piece is accessible to my parents, is making sure that the caregiver is part of that experience from the very beginning. And that is a question that could be asked, is what would make this experience easier for you? Is there someone that can help, right? And not everyone tags themselves with the title of a caregiver, so the appropriateness and timing of the question is also going to be key. Understanding, however, that no two communities are the same. There's going to be broadband issues, internet issues, understanding or just comfort, right, in engaging with technology. And I think it offers an opportunity to really look at our processes a little bit different. I did want to point out data that reflects the telehealth or just patient visit really output before and after key points in time as it relates to the COVID-19 pandemic. And the blue bars indicate prior to telemedicine implementation, so just number of visits or volume of visits, and then the orange bars indicate the after telemedicine implementation. And we see for very specific pockets of patients, right, visits dropped drastically. That was definitely the case with age 65 plus, certainly for those that were non-English speakers as a preference. We certainly saw that primarily with the Medicare population, right? And if we looked at the race side of it, we also saw that with the preponderance here of ethnic groups such as Black and Latinx and Asian Americans. And it just tells the story that there is an opportunity to do things differently, whether it is a language barrier, whether it's identifying the system piece of why is it not working the same as with other groups, just asking that question, the data will inform much of those strategies or potential strategies. And I think it just begs the question on how can we communicate with individuals differently so that there is higher engagement of technology. It's not like we're putting certain groups on the side and saying, no, we're not doing it that way because it's not going to work. I think the story here, Sharon, I think you would agree, is how do we empower our communities to build these capabilities, to build capacity, to leverage some of the resources that historically perhaps they didn't have the opportunity to leverage, learn, or just have access to for a number of reasons.
Yeah, I totally agree. And I think what this points to is you know, in healthcare, I always have felt like sometimes we lack nuance in that, you know, there's a lot to be excited about that I mean, when you think of a silver lining for a pandemic, I want to temper my enthusiasm here, but there's a lot to be excited about in terms of what it's done for the adoption of virtual care and digital health solutions. I think that is meaningful for rural populations. It's meaningful for underserved communities. But the headline of adoption, we still have a lot of work to do. And so before we swing the pendulum very far, you know, I hear a lot, particularly in the last 6 months, about really being focused on digital first solutions. I think there's a lot to be excited about, and I also think there are good reasons to be more nuanced and a little bit tempered in how quickly we move to sort of too far in another direction. So another way of looking at this, just to kind of piggyback off of Vanessa's previous slide, is to acknowledge that that we are seeing incredible momentum around adoption of technology, and oftentimes when we talk about caregiving, we're talking about our aging elderly populations, our seniors, and there's no doubt that we're seeing great momentum in terms of use of technology, purchase of technology, and that creates opportunity. However, you know, there are reasons to be cautious that, you know, as you get into you know, further up on the age scale, then there's a decline in use. There is need for assistance, and you see that in this Pew data about use of the internet, ownership of a smartphone, subscription to broadband. And so, you know, one of the things that we hear a lot is even though we see this big trend and shift to adoption in our seniors, and we talk about how comfortable baby boomers are being online, that is not it's not yet the overwhelming majority. And so we need to be sensitive to those needs. We also, I think, have to think about what types of interactions people want to and are comfortable having with technology or via technology, and what still feels very personal and needs a human connection. So and then the last point here is just from an equity perspective, it's also important to realize that income does come into play here, and that while we see tremendous increase in smartphone ownership as an example, with household incomes for seniors above 75,000, that's well above what we see below 75,000. And so all of these are just a plea to think in a balanced way about how you blend solutions that leverage the momentum we're seeing in digital adoption, but don't leave people behind.
I agree. And it actually brings us to our next point on what can we do, right, to ensure that we mitigate some of the risk associated with the digital and telehealth uptake. And one of which is it's really focusing our attention and applying resources to education and training, not only for the individuals, but also the providers and clinicians who are communicating with individuals, right? And I think it's key. Sometimes we focus a lot of the education on the patient and the member rather than our own workforce on how to communicate some of these things. I highly suggest that. And then there's system barriers, right? There's the literacy piece, both on the health literacy and digital literacy, but there's also, we didn't even touch upon it, but reading literacy, right? At that level. And that's fundamental, right? It's important that your organizations really focus your attention on at that piece alone. Looking at your marketing material, how you engage with these individuals is going to be key in sustaining, but also empowering communities to really leverage technology now and far beyond. And then lastly, you know, how can we create a permanent expansion, we hope, right? Where many of these programs go beyond just a pilot phase and into a much more sustainable funnel. And it's continue the advocacy for low cost and free, you know, broadband. It boggles my mind when I hear that certain states in rural areas, right, have capped capacity when it comes to internet. Obviously, coming from an urban city center, we don't experience much of that, but it's amazing how we sometimes miss the mark in identifying some of these barriers when we're engaging individuals in care virtually. And then switching gears a little bit, but still very much in alignment, is what's at the core of caregiver support, right? What does engagement look like? And for us, from a strategic perspective, that might mean capturing information, demographic information on the caregiver or the partner or support system, right? However, it's appropriate to ask the question, and making it accessible to your individual teams, but really taking the time to build, whether it's your screening, your encounters, your engagement, a process to help identify what are some of those caregiver burdens and stressors. And in some cases, your members are the caregivers or they're being taken care of, right? So it's identifying what roles, and sometimes they're doing both. And sometimes it's even generational. If you're definitely in the sandwich generation, that's definitely the case. So I think identifying that as part of your encounter is going to be key. And like I mentioned, as you identify, educate, and retract your steps as it relates to the literacy piece. When it comes to patient engagement, I challenge you all to work with, regardless of what side of the fence you're in, but most of you will be involved in value-based care initiatives. And into that, in those type of partnerships, it's important that you have the dialogue on how you're identifying resources to support caregivers and members, but with the caregiver in mind as part of that practice, what information needs to be exchanged or data needs to be exchanged, and what type of partnerships can help support, further support caregivers. We often see the community as this entire separate entity. I think it's time to bring the community and healthcare really in a greater alliance, and then that we will be in a much better position of closing gaps on a both clinical but also social level. Ooh, sorry, there you go. And Sarah touched upon this earlier. Income does play a real role in terms of how it impacts an individual's ability to really sustain and manage even the most basic, daily activities. And disparities does exist by race. So this chart actually applies from left to right, lower income households, single households of 65 years and older, to the highest. As you can see, even within the low income populations, right, where this eggplant bar here represents less than $15,000, to the yellow being the highest with over $75,000, that there are real living challenges, right, with those with lower income. And even to further that, to worsen that statistic, we see even a higher predominance of Blacks, Hispanics, and Asians, right, that fall into that riskier category of less than $50,000. So there is an opportunity to really implement a family or caregiver support system that facilitates social resources to engage these members and caregivers, but also for ongoing policymakers to become involved in further supporting virtual and remote patient care.
I know we're getting short on time. It's a big topic, and of course, Vanessa and I are both passionate about it. So we could probably spend another couple hours. We won't, but we could. So I'll try to make short work of the last couple slides here. And Patty, feel free to cut me off if we have any questions we need to get to. But to sort of pull some of this together in terms of caregiver support, I think there are a couple things that I would highlight to suggest to the group. And one is to just acknowledge the broad spectrum of challenges and questions and unfamiliar territory that caregivers face, whether it's the responsibilities that Vanessa has taken on in her family around the healthcare, the legal, the very specialized expertise required for that, versus maybe, I think you said your sister is sort of the more day-to-day, maybe more on the physical and probably both in the emotional zone of what caregiving requires. And we have a habit in healthcare to really focus on the well-being of the member and not the caregiver. And because of the dependence that we have on caregivers, because of the outsized impact that has on different communities based on their resource and access, the support for the caregiver to ensure their resilience is important. And so it's their context that needs to be taken into account. And similarly, they're faced with very different situations, and people find themselves in caregiving situations in unexpected ways and at different points in time. It may be long progressions of chronic disease. It may be a medical crisis that's unexpected. It may be somebody who's planning ahead. And so we need to, in supporting caregivers and their support of a loved one, we need to have some sensitivity to that. And so if we put those things together, caregiving needs need to be emphasized just as much as the responsibilities that we foist upon the caregiver. And so there are, with two things in mind, right? What's the situation and need of the loved one? And what are the barriers and challenges that they may face and the caregiver may face based on the community with which they live or in which they live, and maybe the cultural distinctions between them. And if we can focus on whole person care that includes the caregiver, I think we will strengthen the ability for patient self-management, for the scalability and the cost containment of healthcare in our communities. And that requires programs, as we've been saying throughout, that start with life context and give some optionality for how we problem solve with our members, patients, and their caregivers. So I'll leave it at that, and certainly would love if there are any questions or comments or reactions or perspectives.
Thank you both so much. I've been monitoring everyone's questions, including some of my own, and I feel like you've both done such a wonderful job of answering all of them. It's been extremely helpful, and it was great to hear your personal stories too. We'll give everyone a chance. If you have anything else you want to add to the questions or to Cher's point, any comments, feel free to do that. And Cher and Vanessa, I'll give you the last couple of minutes here to give us any parting thoughts you may have.
Yeah, I think I'd like to end it with, Shara said it best and contextualized the focus on the whole person care and creating programs that is so important. I can't emphasize enough that it's important to also understand where individuals are at, right? Without that, without really knowing what's most important to them and what are the drivers, it's hard to then understand the resources. And Cheryl said it at the beginning, where it's like, let's not just push resources, right? it's important to understand where the needs are. I want us to think about health equity, especially in a caregiver environment, as almost like making generational changes, right? I think by implementing some of these either strategies or solutions or initiatives, we are making generational changes here, right? There's a cultural piece, there is an age, there's all the social determinants or factors, right? But I think it'll carry on into the future as long as we make the vetted interest of integrating caregivers into the space as we engage members in care.
I think that's right. I think that's the mic drop for the session. So I'll just leave it with, you have both Vanessa and my email addresses. It's a topic that we are obviously passionate about and want to help address. And so if you have questions or comments or feedback or ideas or whatever it might be, please feel free to reach out. And thank you, Patty, for helping contain us in this conversation.
Thank you both so much. I think when insights meets passion meets practicality, it's exciting to see where we can go from here. But to Vanessa's point one more time, getting out of the standstill, I think, is what's most important. So thank you both so much. Thank you to Carolel and to SmartRise Health for sponsoring today's session. And we'll see you next time.
Thanks, everybody. Have a great day.
Bye-bye.
Bye.